It's my great pleasure and privilege to invite you for this Wednesday webinar of the Indian College of Anaesthesiologists. This ICA webinar is a hallmark of the Indian College of Anaesthesiologists being conducted on a regular basis every Wednesday from 7 to 9 p.m. Indian Standard Time. And Indian College of Anesthesiology is devoted and committed to the academic advancement of trainees and practicing anesthesiologists all over the nation. And we also have participation from other countries. ICA, that is the Indian College of Anesthesiology, conducts various fellowship programs which have been highly acclaimed and with good impact on the provision of healthcare services in the form of various techniques of anesthetic approach to patients with diseases. With that brief introduction, it's my great privilege to host this program on behalf of the Indian College of Anesthesiologists. And today's focus will be a perioperative neonatal cardiac care. We'll be dealing with cardiac patients who are neonates undergoing surgical procedures and their perioperative care. That is the crux of the discussion today. We have four eminent speakers for that, and we also have, including me, four panelists come moderators. We have Dr. Rupa Sridhar, who is the Chief Anesthesiologist at Gokulam Medical College. We are really grateful and thankful for your presence, madam. Thank you so much. And next we have Dr. Srinivas, who is accomplished cardiac anesthesiologist of the Sri Chitra Medical Institute in Trivandrum. And I think Keshavamurthy has joined. Dr. Keshavamurthy is my colleague from Narayana Bangalore, and I'll be with you all through. I think Ganesh may not be joining. With that brief introduction, I would like to invite Dr. Rupa to take over. Before that, the housekeeping points are that the question and answer at the end. Please stay till the end, and any question or comment may be posted in the chat box. We'll try to resolve all the issues which have been raised, which may be raised at the end of the session. And I request all of you to keep the mics muted, except those who are moderators and those who are actually speaking into the meeting. With that short brief, I request Dr. Rupa to take over and do the meeting. Thank you so much, and we're looking forward to a great discussion.
Thank you, sir. The first speaker is Dr. Gayathri Gopan. Dr. Gayathri Gopan works as Assistant Professor of Cardiac Anesthesia at Sri Chitra Tirunal Institute for Medical Sciences and Technology. She completed her DM in Cardiac Anesthesia and the postdoctoral fellowship in Pediatric Cardiac Anesthesia from the same institute. She has a gold medal for FIACTA Pediatric and a first prize for oral presentation in the 17th annual TE workshop at PGIMAR Chandigarh. Dr. Gayathri will speak to us about blood and blood product transfusion during perioperative neonatal cardiac surgery. Dr. Gayathri, please.
Thank you, ma'am. Is my screen visible to all?
Yes.
Yes.
Thank you. Good evening, everybody. Today, my talk is on blood transfusion in neonatal cardiac surgery. So first, we'll see about some physiology. So in a neonate, what is different from the adult is that they have low coagulation factors. That is the vitamin K dependent factors like 2, 7, 9, and 10, and the contact factors like 11 and 12. They are around 30 to 50% of adult values. Also, this is balanced by low anticoagulant factors also, like low levels of antithrombin 3 and protein C and protein S. So under normal physiological conditions, this is balanced by the low levels of both procoagulant and anticoagulant factors. Coming to the platelets, they are hyporeactive. So that is basically due to reduced alpha adrenergic receptors, also reduced PAR1 and PAR4 receptors on the surface of the platelets. But they are also balanced by higher levels of von Willebrand factor and the rheology of blood, that they have they are more viscous. So the thing is, the reserve capacity of pediatric coagulation system is limited, because an adult can tolerate around 30% drop in coagulation factors, but the neonate reaches threshold faster. So what is special in neonatal cardiac surgery? The first thing is CPB. Then we have children with cyanotic heart disease. Then we have children in heart failure who has anemia. And there are a lot of complex procedures with a lot of suture lines which will bleed, and redo surgeries which will bleed. So, 1 second. First, we'll go to the primary insult, that is the cardiopulmonary bypass. So, the blood volume in a neonate is around 85 ml per kg, and our minimum pump prime volume comes around 200 to 300 ml. That is, there is massive hemodilution, which reduces the coagulation factors to 20 to 30% of their baseline values. On top of that, the CPB surface triggers inflammation and coagulation cascade, leading to consumptive coagulopathy. Also, the platelets are also damaged due to high shear stress, which will rip the platelets of the receptors. So this hostile environment, we call it the lethal diamond. The four corners are hypothermia, coagulopathy due to dilution and consumption, hypocalcemia, and acidosis. On top of that, we have cyanotic infants with baseline polycythemia, lower coagulation factors, and chronic hypoxemia. So this is a guideline which came out in 2019 in the JCVA. The NATA guidelines are one comprehensive set of guidelines which specifically caters to the neonatal population. So we will discuss this in the coming slides. So first thing to deal with coagulation abnormalities in neonates are first to optimize them preoperatively. Anemia we can manage with IV or oral iron. Guidelines also recommend erythropoietin for rare cases and specific cases like Jehovah's Witness who don't accept blood products. And in a stable neonate without any history of bleeding, we can avoid routine screening for coagulation parameters. Also, if we have to transfuse, how to transfuse? Do we go for restrictive transfusion strategy or liberal strategy? So the liberal strategy has a higher hemoglobin threshold, and a restrictive strategy has a lower one. So I quote the TRIP ICU trial, which came out in NEJM in 2007. They have two groups with a restrictive hemoglobin threshold of 7 gram per deciliter and liberal threshold of 9.5 gram per deciliter. So they found that there is no significant difference in mortality and also organ dysfunction in stable neonates. So even the NATA guidelines recommend hemoglobin threshold of 7 for stable acyanotic patients. But the problem is we do not always have acyanotic patients. So in a stable postoperative neonate, if it is a biventricular physiology or a non-cyanotic physiology, we can have a restricted trigger. That is a hemoglobin of, we can transfuse when the hemoglobin goes below 7 gram per deciliter. But in case of a single ventricular or a cyanotic physiology, we have to have a higher threshold of 9.5. On top of all this, if there are signs of dysoxia like low NIRS, high lactate, low mixed venous saturation, we should transfuse regardless of hemoglobin. So in the NATA guidelines, it is a class 1 recommendation to avoid transfusion if the hemoglobin is above 7 gram per deciliter in acyanotic children. Next is why so much about restriction. So that is basically because of the complications of blood transfusion. So one specific complication, which is more common in preterm neonates, is TANIC, that is transfusion-associated necrotizing enterocolitis. The physiology has a two-hit hypothesis. That is, when the gut is anemic and hypoxic, on top of that, when we transfuse, there is reperfusion with release of cytokines, which will lead to NEC and injury. So this is more common in preterm neonates and also with children with some sort of systemic steal like a BT shunt or a PDA. And one clinical practice guideline to prevent TANIC is to withhold feeds during transfusion. We call it as WOD. And other complications everybody is familiar with, like transfusion-associated circulatory overload, TRALI, and transfusion-related immunomodulation. Beyond the gut, there are neurodevelopmental and cardiac complications. Like the Boston Circulatory Arrest Study states that higher transfusion volumes of RBCs leads to lower cognitive and motor scores at the age of 1 and 5. This is evidenced by increase in inflammatory markers like S100 beta and neuron-specific enolase with rising transfusion volumes. To the heart, there is risk of hyperkalemia, especially when we deliver little older blood through the central line right into the right atrium. So we can prevent it by washing the RBCs to prevent hyperkalemia. And next controversy comes whether we should use stored blood or fresh blood. Fresh blood is blood which is given within 7 days of collection. The rest we refer to as stored blood. Stored blood will have low 2,3 DPG. That is, there is poor oxygen offloading. There is risk of hyperkalemia, and inflammatory cytokines are also present. But evidence does not mandate the use of fresh blood in neonates, even though there is decreased incidence of hyperkalemia and lactates. There is no mortality benefit, or it does not have any effect on length of ICU stay. But in cyanotic children, it is found to have more benefit, that it reduces the ventilatory days. But overall outcome is not changed with use of fresh blood in neonates. Nevertheless, generally we tend to use fresh blood in neonates. Other types of products which we can use is, one is irradiated RBCs. Irradiated RBCs are used in immunocompromised children, like in a Dye-George syndrome. So the gamma rays destroy the donor lymphocytes, but they also damage the cell membrane of the RBCs, which leads to hyperkalemia. So a way to go around it is to wash the RBCs before you transfuse. So that will lead to less hyperkalemia and inflammatory cytokines. Other pharmacotherapy, what we can give is antifibrinolytic. So our routine practice is to give tranexamic acid. That is a first-line drug which we use generally. We can use a loading dose and an infusion. But only the only thing is, and high doses, that is very high doses, they have a risk of seizures in children. So generally the recommended doses are 10 to 15 milligram per kilogram bolus followed by infusion. There are various protocols which we can follow, but at least one single dose should not go beyond 50 milligram per kilogram. Next is epsilon aminocaproic acid, which has a similar profile to tranexamic acid. Aprotinin is superior in terms of less inflammatory effects and everything, but it is a re-emerging drug. It has gone out of market for a while and now it is re-emerging. So what can we do to the CPB circuit? One is miniaturization. We come down on the volume as much as possible. We take out all the unnecessary connections. We change to the lowest available, lowest possible tubings and everything. So, and also the priming fluids, instead of crystalloids, we try to use albumin or other colloids to maintain the oncotic pressure. Coming to blood products, we can add FFP to the prime in neonates less than 30 days to prevent dilutional coagulopathy. Generally, we can, if the child is anemic, we can use a blood prime also. And there is something called as retrograde autologous priming. That is, the crystalloid is replaced with the prime from patient's own blood. But that is really difficult in a neonate without causing any hemodynamic instability. But in infants more than 4 kilograms, we can try it in stable patients. And another very, very important aspect is modified ultrafiltration. This raises hematocrit by around 10 to 15% post CPB, also removes the inflammatory cytokines. So that is very beneficial in neonatal cardiac surgery. We should do MUF at least more than 10 minutes after CPB. So anticoagulation and reversal, general things, we give heparin at around 300 to 400 units per kg with a target TCT of 480 seconds. And but in neonates, the problem is they have low antithrombin levels, so they can have a little bit of heparin resistance. If there is heparin resistance, we can give initial 100 units per kg bolus. And if it is still resistant, 10 ml per kg of FFP is recommended, or antithrombin concentrate we can give. And reversal with protamine, the warning is we should not reverse 1:1. We should always go for titrated doses according to heparin concentration. Excessive protamine can also cause increased bleeding. So how do we diagnose coagulopathy? So the best thing is to go for viscoelastic testing. So that they give real-time coagulation parameters, and it is very reliable in pediatrics. So in neonates have one thing we have to know is they have little hypercoagulable state. That is, they have shorter R times normally. But they give TEG and ROTEM gives reliable estimation of coagulation. So in TEG, if R time is too long, you give little FFP. And if the maximal amplitude is low, you give fibrinogen or platelets. And LY30 is high, you give Tranexa. The conventional lab values like prothrombin time and partial thromboplastin time is a little less reliable in neonates. And also it takes a longer time to get in intraoperative setting. And what about platelets? Should we give prophylactic platelet transfusion? That is generally practiced in neonatal cardiac surgery. But there is a Planet 2 study which which compared two thresholds for platelet transfusion. The first group had a 50,000 threshold, and the second group had a 25,000 threshold. When the platelets were transfused, when the platelet count was above 50,000, they had a 26% more mortality and bleeding risk, which was reduced to 19% when the threshold came down to 25,000. So this shows that unnecessary prophylactic platelet infusions are not necessary, but in case of clinical bleeding, we can give. So the problem with platelets is that, first of all, we are giving adult platelets. They are hyperreactive compared to neonatal vascular blood. Also, they have inflammatory mediators which are present with the platelets. So prophylactic transfusion is associated with increased harm. So do not treat a number. Treat when there is increased bleeding or evidence of platelet dysfunction, as with the viscoelastic tests. So in managing hemostasis post CPB, the first thing we should think of is fibrinogen, because that is the first factor to deplete to critical levels on CPB. So if the fibrinogen levels are less than 1.5 gram per deciliter, you give fibrinogen concentrate or Caroy precipitate. Fibrinogen concentrate has an advantage that the volume is very less. But cryoprecipitate is 4 months fibrinogen concentrate. We can always give that. And second thing, in spite of giving cryoprecipitate, if there is bleeding, we can think of giving platelet transfusion. Because as we know, CPB damages platelets. Even though the number is not reduced, the function is reduced. So, but what not to give? The prothrombin complex concentrates, recombinant factor 7A, and desmopressin are recommended against by NATA guidelines, because they have higher risk of thrombosis and less safety data in neonates. So coming to the conclusion, when we are managing a neonatal cardiac surgery, we should respect the physiology. We should understand that there is less reserve for the neonates, and they can go for coagulopathy when there is slightest tilt of coagulation factors. So, and thresholds, as far as possible, we adopt restrictive triggers, but always look for signs of dysoxia and treat accordingly. And for diagnosis, go for viscoelastic test rather than conventional prothrombin time and partial thromboplastin time. And blood conservation strategies like MUF, cell salvage, miniaturized circuits, retrograde autologous priming should be followed universally. And in future, probably we can see more of artificial blood, and genomic profiling may come up to assess risk of bleeding in individual patients. Thank you. That's all.
Thank you, Dr. Gayathri. A very nice and precise presentation. May I introduce the next speaker? I will have discussion at the end of the 4 sessions. So may I invite Dr. Diana. First, I'll introduce Dr. Diana. She did MD from JIPMER, and then she did her DM from Shri Chitra, our institute. And she's having nearly 3 years of post-DM experience. At present, she's working in Amritha Institute of Medical Science at Cochin. And since last 2 years, she has dedicated to pediatric cardiac anesthesia. Very hard working and enthusiastic anesthesiologist. She's having 11 publications. So she's going to speak about the oxygenation and non-invasive ventilation of neonates in the cardiac surgery ICU. May I invite Dr. Diana to present this.
Thank you, sir. Thank you for your kind words. Is my slides visible?
Yeah, your slides are visible.
Thank you for this opportunity. I'll be discussing about oxygenation and non-invasive ventilation in neonates in the cardiac surgery ICU. So I'll be dealing with both preoperative and postoperative scenario. We will see how oxygen and how and why oxygen is considered a drug. We will see the physiology of oxygen delivery, briefly about neonatal circulation and the physiology of congenital heart diseases. And we'll also look at some oxygen therapy devices and non-invasive ventilation devices. Now, oxygen is considered a drug. And this implies that adequate oxygen delivery is what you target at. It does not mean you have a normal saturation, and the normal saturation does not mean that you get an adequate oxygen delivery either. Instead, what we aim for is to have a good cardiac output, a fair hemoglobin, and oxygen saturation. To understand this, we see that the cardiac to adjust the cardiac output to get a good oxygen delivery, we need to understand the disease-specific physiology. Hemoglobin should be maintained according to the disease specificity again, and arterial saturation is an area that is dependent more on the lung mechanics and alveolar hypoxemia. So these three combine and help in maintaining an oxygenation in a child. Now, to understand this physiology, we should first, in this group of children, unlike an adult, they come with a neonatal transition circulation. Unlike a normal child who has a normal neonate who transitions after coming out of his womb, a child with critical heart disease affects the stability at birth. In addition to that, if the child is premature or has a respiratory pathology, this also affects how the child behaves outside his womb. Now, to look at the fetal circulation, while in the womb, the oxygenated blood comes from the placenta. So this mixes with the deoxygenated systemic venous return from the IVC. All of this go into the RA. 50% of this crosses across to the LA and goes to the LV and then reaches the systemic circulation. This then supplies the heart and the brain. The remaining 50% goes through the RV to the PA, does not go to the lungs. Instead, through the PDA, joins the aorta and supplies the descending thoracic aorta and the systemic vessels. So this is what happens in the parallel circulation within the womb. So there are two communications that are essential to make sure that so one is the ductus arteriosus and the other is the foramen ovale. Now, what happens when the child is born? So the first cry that he takes, that causes the lungs to expand. This causes a drop in the pulmonary vascular resistance, encourages pulmonary blood flow to happen, causes reabsorption of the alveolar fluid as well. At the same time, the umbilical cords get clamped. So here there is a rise in systemic vascular resistance. Now, because of the increase in pulmonary blood flow, there is an increase in the pressure in the left atrium and the foramen ovale closes off. And there is no more mixing that happens in the atrial level. Instead, oxygenated blood is able to pass into the left ventricle and to the aorta and to the systemic vessel. Now, the deoxygenated blood, therefore, gets cordoned off into the RA and the RV, is able to pass through the PA and goes to the lungs, which has had a drop in PVR. At the same time, since there's been an increase in SVR, the ductus arteriosus reverses, it constricts and closes off maybe within 2 weeks. So these changes happens in all children, and in all normal children, this is what makes them survive. But in a child with complete complex heart disease, this changes, especially the closure of the ductus arteriosus, can unmask certain duct-dependent lesions. This can present in the form of shock, cyanosis, or pulmonary edema. This means that all of them will require oxygenation or ventilation in some form or the other. And in them, these can act as vascular drugs. It can cause a change in the pulmonary vascular resistance, all of which will modify the QPQS balance. And we need to know how to maintain this balance to make the child survive. This implies that we should not be using hyperoxia routinely in these children. We should understand the physiology and individualize the SpO2 targets and must respect ductal physiology. So in total, oxygen therapy in neonates aims at providing adequate oxygen availability to tissues, making sure that there is an improvement in the incomplete hemodynamic adaptation that has happened in the extrauterine life. At the same time, avoiding oxygen toxicity to the eye, brain, and other organs. Now, to understand physiology, we'll divide complex heart diseases into 4 broad categories. The first is the duct-dependent pulmonary blood flow. So this pulmonary blood flow is affected, so it is dependent on the duct. Cases like pulmonary atresia, TOF, severe PS, or tricuspid atresia. Now, the other group is where the systemic outflow is obstructed. So the duct is dependent for systemic outflow. It's critical coarctation and interrupted aortic arch is some examples of that. And then there are others where we need parallel circulation or where we need good mixing to happen within the heart. So TGA with intact septum is a classic example of that. And then we have the left to right shunts, which comprise of VSD, AVSDs, and large PD. So these first 3 groups, we do not have to, we know that mixing is happening in the heart, and we target a saturation of only 75 to 85%. We do not give oxygen or ventilation to target a higher level. And in the fourth group, we can target more than 90%, but never 100%. Now, this was how the complex heart disease affects a neonate. There are other lung or thorax related factors in a neonate that can worsen this condition. So neonates usually have a compliant chest wall that will cause an inspiratory collapse of the chest wall. There's an inward movement of the chest wall that itself can cause a collapse of the lung. They have a low functional residual capacity. They might have surfactant deficiency and VQ mismatch and shunting. Really premature children or children born to diabetic mothers may have an immature respiratory drive or muscle fatigue and apnea of prematurity. All of these can add to the cardiac-related respiratory insufficiency in this group of children. Now, how do you decide the ones who need help? Is SpO2 the only indicator? No, we discussed that saturation cannot be relied upon. So we'll see for these clinical indicators. Children with tachypnea, substernal and suprasternal retractions, grunting, nasal flaring, peel or cyanotic skin, agitation, apnea of prematurity, these are more of the preoperative conditions. And then electively, we might need to oxygenate and provide therapy to children who have been recently extubated, the ones who are prone to tracheomalacia or abnormality of the lower airways. And then even in the postoperative period, we might have transient tachypnea of the newborn. So red highlighted ones are the factors that are the common symptoms that we see in a neonatal ICU or in the post-delivery suite. And recent extubation is an elective reason for starting NIV. And then there is tracheomalacia as well. So the general guidelines would be to avoid hyperventilation and alkalosis, allow a little hypercapnia. So we have certain children who require this, especially after maybe a PD stenting or children with BT shunt or PA banding. So we need to have a good balance of PVR and SVR. So this is the whole target of having ventilation, especially in children who have had only palliative surgeries and not a complete repair of their cardiac condition. Hemoglobin, again, we need to understand that oxygen content is more important. So depending on the cyanotic, as was discussed in the previous session, depending on what the complex heart diseases in the child, we need to decide on we need to have a threshold on the hemoglobin. Anemia has to be avoided. In addition, these are the things that we should look for. It's not just saturation, we have discussed that. And even if it's in the preoperative phase, we need to see both the pre and post ductal saturation, especially in children with interrupted arch or a coarctation. In addition, more important are the lactate trends, the urine and the urine output. So this will tell us very informatively about the oxygen delivery in cell tissues. NIRS, if we have it, we can use it. Now, what are the strategies that we have? Oxygen supplementation, very, very simply applied, is usually preferred in stable preoperative heart disease children. Most common ways we use is oxygen hood, face mask, and nasal cannula. So when we have children who are stable after birth, they have low FiO2 needs, low flow requirements, and have patent airway. These are the best methods to make sure that they tide over the early phase of poor oxygenation. Oxygen hood has an additive advantage that as we discussed, when we have situations where we want a higher CO2 levels, this helps. Oxygen food helps. So this is about oxygen supplementation. Now, when do we use non-invasive ventilation? There are multiple areas where we use it pre-op and post-op. Pre-op in children with newborns with respiratory distress syndrome, where we have a surfactant deficiency. During transition after birth, apnea of newborns, extremely premature, low birth weight children might have this. Then there are some group of children where, especially left to right shunts, where there are cardiac benefits. The positive distending pressure might slightly help in reducing the left to right shunts and reduce failure. Then post-operative period in the early post-extubation, when we want to tide over that immediate phase, then NIV helps. And to avoid reintubation in some group of children, where there might have a temporary respiratory distress or central apnea. So the methods, most common methods are three: nasal CPAP, nasal intermittent positive pressure ventilation, and high flow nasal cannula. Now, nasal CPAP, basically, as the name suggests, delivers a continuous positive pressure to the airways via nasal interface. So this has a soft sealing short nasal prongs connected to a bubble CPAP. This is how it was initially used. Now, even our modern Mac ventilators have nasal CPAP mode in them. So the benefits were that this prevents alveolar collapse, it stabilizes the FRC, it helps in reducing pulmonary shunts and provides better oxygenation. And the large and small air as well, it stabilizes and decreases the work of breathing and episodes of obstructive sleep apnea that might occur. So these are the benefits of nasal CPAP. On the other hand, when we have a non-invasive positive pressure ventilation, we give cycles of relatively small positive pressure at nose or the upper airway, basically. How we give an invasive ventilation, but it's not invasive, it stays in the nasopharynx. So these have been found to have more benefits than nasal CPAP. One of their major factors is it helps in central apnea. Nasal CPAP has no role in central apnea, but having a positive pressure intermittent ventilation helps in central apnea, delays the period, delays the onset of, delays reintubation, avoids reintubation. It helps in increasing CO2 elimination and oxygenation, maintains lung volume better. It helps better gas exchange and ventilation. So these are the usual targets that we use when we are placing a child on nasal in IPPV. So there is evidence showing that this method is better than nasal CPAP, especially when we have central apnea, a weak respiratory pump, and poor lung mechanics. I would like to emphasize that this is the preferred method, especially when we are dealing with really tiny babies who we do not want them to struggle while extubating for the risk of stridor, for the risk of pulmonary hypertensive crisis. In these children, we prefer to extubate them in a sedated or in a slightly like we don't want them to actively or vigorously cry after extubation. So in these children, to avoid the disadvantages of extubating a sedated child, this is a very good method to avoid respiratory collapse or alveolar or lung collapse. And yes, there's a definite advantage that NIPPV can be provided with conventional time cycle pressure limited ventilators. These are the common interfaces that we have. They have Argyle prongs. I don't know whether it's available in India. We definitely have Hudson prongs. We have a nasal mask, a RAM cannula, and I'm not sure about Inca prong. These are some other interfaces that we have. We do not, it's not available in our hospital. I think there are studies abroad about this binasal airway. This is what we use. More common than a nasal mask. We actually use a fashioned endotracheal tube that stays in the nasopharynx. We cut it so that it's within the nasopharynx. Now coming to high flow nasal cannula, it delivers a continuous distending pressure, but this is very variable. That is the major disadvantage of this method. The effectiveness of this depends on the flow rate of gas and fit of the nasal cannula. It does help in washing out dead space gases. This is practically very useful. It is easy to use. It is less risky to the nares. It increases patient comfort as well because we can in a low rate start keep the child on soother or maybe start a little bit of oral feeds as well. but the failure rates with this method have been found to be extremely high. So benefits are it's a good method to wean after extubation and wean from CPAP as well. If we have a child who has been chronically on NIV or CPAP, then this is a good method to wean that child off. It also helps in some cases of respiratory distress syndrome. Basic advantage of improving oxygenation and providing a low level of PEEP is what keeps high flow nasal cannula in our armamentarium. Now, in general, the complications of NIV are related to the interface. They can cause pressure necrosis, can cause some gastric distension, also some pulmonary interstitial edema as well. We'll add some of the last slides. We also need to know when we have to stop, depending on the NIV, when we need to go up on the support of NIV or reintubate the child. So these are the risks that we look for. If the child has an increased work of breathing, there is respiratory distress, altered sensorium, increasing CO2, or hemodynamic instability. That's when we need to reassess and increase our respiratory support. So the usual causes need to be ruled out, like diaphragmatic palsy, sepsis, residual surgical defects, neurological compromise, any pleural effusion or pneumothorax, and a low cardiac output syndrome as well. So to conclude, we need to, the choice of NIV for a neonate should be individualized. It should be based on the disease pathology he's on, our resource settings, the clinician's familiarity, and parental values as well. Now, this is what we have experienced the last less than 2 years, where we have catered to 117 neonates. 95% of them we have extubated to non-invasive positive pressure ventilation. And as I said, 95% of them we have used the nasopharyngeal ET tube. Very few of them have received a nasal mask or a Rams cannula. And in them, we have had 20% of them getting reintubated, and around 8% we have had to reinstitute an IV after taking them off an IV. That's my time. Thank you.
Thank you, Dr. Diana, for a nice presentation, very comprehensive, and you elaborated all the practical aspects of NIV and oxygenation. I think Dr. Rupa will invite the next speaker, introduce the next speaker.
Yes. Professor Bhargava D completed his MD and DNB from AFMC Pune, did his DM in cardiothoracic and vascular anesthesia from Sri Chitra Tirunal Institute of Medical Sciences and Technology, and is presently working at the Army Hospital in Delhi. He has competence in advanced perioperative transesophageal echocardiography and is certified by the National Board of Echocardiography, USA. He has several publications and has won several awards. He will talk to us on neonatal resuscitation during perioperative cardiac surgery. Dr. Bhargava, please. You can start.
Thank you, ma'am, for the kind introduction. I hope my slides are seen.
Yes, they are very well seen.
Right. Thank you. So, firstly, perioperative neonatal resuscitation during cardiac surgery. It's a very specific thing. We know about the neonatal resuscitation protocol, and we also know about the cardiac surgery. So now, once you have two high-risk situations coming together, the entire game changes. So I will be dealing it with this topic in terms of, first, we'll go briefly through the AHA, the AAP guidelines on neonatal resuscitation that is specific to the delivery room. Then, how is this perioperative neonatal resuscitation in general different? What is the information? What is the literature available on that? What are the causes for neonatal cardiac arrest in the perioperative period in general and specific to cardiac surgery, and management of various scenarios with some experience and examples. So the chain of survival, the neonatal resuscitation guidelines of 2025 is a little more elaborate than the ACLS and BLS for the adult. So about 5 to 10% of newborns require help in terms of some respiratory support, and very rarely about 1% require advanced resuscitative measures in some terms of some fluid or epinephrine or intubation, chest. So in spite of that, the neonatal mortality is quite reasonable. So for NRP to be effective, it requires adequate skills. You need skilled people with the right equipment and preparation. And the moment respiratory support is adequate, there's a tremendous improvement in heart rate. That is primarily the way it is assessed. And then there are specific guidelines for each cutoff of heart rate to less than 100. We start ventilation support with a mask and probably with LMA, and if required, intubate. And if heart rate is less than 60 in a neonate, it is considered as good as arrest. And hence one starts chest compression and epinephrine boluses. And there are guidelines which speak about postnatal care, specifically related to problems like hypothermia and hypoglycemia. Coming to specific guidelines, briefly, if you the airway anatomy is little different in neonates. We have a large occiput. We know all this: floppy epiglottis and high larynx. Airway manipulation, the first attempt has to be the best attempt. Avoid multiple attempts. Prepare well and give a good attempt with the right equipment and right tube. Then reposition, suction the airway, have the all the equipment available with the best available person with best expertise for intubation. Then maintain optimum airway pressure when you do the mask ventilation. Position the head properly. Then, if required, go up. The moment there is adequate positive pressure ventilation, the moment it happens, there is rise in heart rate. So, if you look at the NRP, it is a birth initiate cord management plan. There is literature about delayed cord clamping. Then look at the cry, the color, then Apgar score. There are various things. And coming to the heart rate and ventilation, specifically, all these have been discussed in the NRP. So for us, what is important is, apart from the heart rate targets, how much oxygen we should be giving. For terms, there is air is more than enough. That is 21% more than there is no need for oxygen supplementation unless there is a preterm baby. Then targets for SPO2 goals, we need not get 100% saturation right at birth. So depending on the timeline, as you can see on the left side, for 2 minutes, 5 minutes, and 10 minutes, the targets are completely different. Then coming to the chest compression, there is a specific change which says that earlier there was a choice between two finger technique and two thumb and chest encircling technique. So with two thumbs you compress and encircle the chest with your hands. That is the preferred method today, and the two finger technique over the sternum is no more recommended. Depth, it has to be 1/3 of the chest diameter and 3:1 ratio. And the moment the heart rate is less than 60, epinephrine and compressions come into place. And there's a lot of literature about what is the route preferred, IV by the umbilical vein or intraosseous is also preferred. And in rare cases, endotracheal tube if the IV access or any access is not available. So coming to that is the NRP. Now coming to the perioperative neonatal resuscitation. Specifically, if you see the incidence of perioperative arrest as per one estimate is about 177 per 10,000. But if you see specific to our population, congenital patients undergoing congenital cardiac surgery, in a large study of almost 19,000 patients, it was found to be about 0.38%. So there was a multivariate modeling which showed that decreasing age, lower the weight, more is the risk of perioperative cardiac arrest. Preoperatively, the child has already undergone a cardiac arrest and has survived. Neurological injury, higher stat score for the type of surgery, urgent surgery, increasing over time, and the abnormal glucose levels. These are all associated with poor outcomes in congenital cardiac surgery. So naturally, the perioperative neonatal resuscitation protocols gap the NRP and the perioperative needs. Because the neonate who is coming to the OT for a cardiac surgery or any kind of surgery has got immature organs, there's a risk of hypothermia, there may be associated congenital anomalies. There could be so many perioperative triggers starting from anesthetic induction to surgical stress incision, positioning, and difficulty in monitoring in such babies. So the difference is In terms of settings, obviously, the entire setting is different for a periop neonatal resuscitation. The goal is just not transition from intrauterine to extrauterine life. It is about stabilizing the vital functions during the entire perioperative stressful surgical period, where there is a lot of multiple assaults in terms of surgery or anesthesia-related manipulation. Then interventions are just not about drying, warming, and stimulation. They are much more than that. Keeping the baby dry, warm, but also having adequate monitors in place with adjustment of anesthetic administration so that you don't overdose, underdose as per the requirement. One has to secure the airway for sure in most situations of neonatal surgery, and most of them coming from emergency surgery in the neonatal period always have metabolic derangements. And so the team which is comprised of the perioperative neonatal resuscitation is completely different from what you see in a delivery room. In the OT, it's the surgeons, the anesthesiologists, and surgical nurses, and the assistants who are doing the job. So, what are the high risk features? Some are high risk anticipated, some are unanticipated. Anticipated when you have a premature baby with low birth weight coming up for emergency surgery already in sepsis, it's a known risk factors. And then there are some unanticipated like airway obstruction, sudden surgical blood loss, and things like that. So we have so many problems which may come in place. But the red flags are if you have a heart rate which is dipping and coming down below 100, or there are new onset arrhythmias, specifically bradyarrhythmias, loss of arterial waveform, BP less than 50th centile for the neonate, and dark blood in the field. Loss of any arterial waveform once you have secured it these are all immediate actions. These are all things which require immediate action. So preparation and optimization of the baby, the neonate is very important. So as I said already, best skilled person, best equipment, warm OT, appropriately prepared drugs, the concentrations taken care of, the dosage all rehearsed and discussed. Then the best skilled person for airway as well as the vascular access, and avoiding and optimizing all these problems like airway obstruction, positioning, hypovolemia, warm fluids, electrolytes before the baby comes to the OT if as much as possible is important. So pre-op survey will make a lot of give us a lot of understanding as to how the baby is doing in terms of color of the baby, the breathing, conscious level, how the baby looks in terms of capillary refill time, then the pulse oximetry, echocardiography, and some baseline NIRS. There are studies which talk about baseline NIRS and the outcomes. So, specific like the ACLS algorithm, there have been perioperative algorithms proposed for perioperative management. This specific algorithm published in 2018 is specific for adults, but there are certain things which are peculiar in this, like communicate the change in status with the surgeon so that he can stop the surgery. Then we ventilate immediately with 100% oxygen with IV wide open. Then thinking of some other cause, it's just not 5H and 5T. There are other causes which could be very vague things like, a local anesthetic toxicity, which could be unexpected, or a hyperkalemia, or just an embolism, right? So, and then if it could be simple hypovolemia for a baby who is just about 2.5 kg, as little blood loss could be catastrophic. So that could lead to a pulseless electrical activity, sudden air embolism, high neuraxial, then intra-abdominal hypertension. So many things which are little different from the usual neonatal causes. Then in also we consider ECMO early. Same thing like the ACLS guidelines, there are bradycardia algorithms as well as the tachycardia algorithms which have been proposed. These are specifically for all populations, more so for the adults. So perioperative cardiac arrest in general in neonates and children are broadly in these headings, but more important are anesthetic induced low SVR and myocardial depression comes in first. Chest wall rigidity, specifically with very small babies, when you give a large dose of fentanyl, even if you give about 5 mics of fentanyl in a 2 kg baby, you might end up with a chest wall rigidity. Suddenly, a sudden administration of KCL without taking care of the rate of administration can also lead to arrhythmias, metabolic derangements. Some little blood loss may precipitate catastrophic hypovolemia and metabolic acidosis. And then hypoglycemia, hypocalcemia, hypothermia are always there. So, I will just go through one or two scenarios where hypoglycemia is very important in a unit. Guidelines say about 40 is the cutoff when we start treating. You always treat with 10% dextrose or of 2 ml per kg over 1 minute. We avoid any higher concentration of dextrose to avoid rebound hypoglycemia. And apart from that, you check it after every 15 minutes. And if it is occurring repeatedly, you ensure the glucose infusion rate of the fluid that we are giving is at least 6 milligram per kg per minute. And any glucose concentration about 12.5% is preferably given through the central line. That is one thing. Hypotension, I have already dealt about it. So airway manipulation, like in all babies and all patients, it's always to be done carefully. Hyperkalemia, anaphylaxis, specifically if you look at the doses, dose for epinephrine is 0.01 milligram per kg, which actually turns out to be 0.1 ml per kg of 1 is to 10,000 epinephrine. Rest of the guidelines as per the ACLS guideline. But this dose is one thing of atropine and epinephrine that one could actually remember. And specific to neonates or children with cardiac problems is the drug-dependent lesions, which Dr. Diana has already spoken about. So one dictum is all cyanosis does not resolve with additional oxygen. So if you have a drug-dependent pulmonary circulation or a systemic circulation, the maintenance of that PG infusion with through a good IV access saves then just giving additional supplementary oxygen. And as in this situation shown on the right side. So there was also a publication in 2023 about neonatal algorithm for intraoperative cardiac arrest, which is essentially the same thing in a refashioned way, with the careful way, with certain things being cared about, which are specific for the neonate. And there's also a role of point of care. Yeah, there's also a role of point of care ultrasound. These are, what you see in the slide are TE images, but you could also have the transthoracic images in the post-operative period, where you can get subcostal or some transthoracic views, where you can easily diagnose whether it's a hypovolemic situation or a tamponade in the post-operative period, or just hypovolemia. Then what you see in the center is the sternotomy tray, emergency sternotomy tray, which you will find always in any cardiac surgery unit, post-op cardiac surgery ICU, where it is important to be kept ready with these items available as per the guidelines published in 2018, where there should be a team which is always available to do open the chest and do a open cardiac massage. So, yeah, one more thing is regarding the shock for a child. I mean, for the neonate, the shock to be given is 2 joules per kg, and next dose should be about 4 joules per kg for any shockable rhythm. And dose for amiodarone, which one should remember, is 5 milligram per kg IV. And to the next one is, like I already talked about, the emergency opening of the sternum. And also there's a guideline about what are the roles that one should take over when a patient or a baby arrests in the ICU. There are specific roles specified for each one. One goes for cardiac massage. Once the sternum is open, goes for the internal cardiac massage. Then airway breathing, one looks after the defibrillation. There's a team leader. One looks after the drugs. And essentially, for neonates, there's a big role of extracardiac life support, extracorporeal life support very early than in other populations. Because I'll come to this thing in the next slide. There's a lot of role for extracorporeal life support early in the post-operative period. So most of these perioperative causes are reversible in nature. So most commonly you might find myocardial dysfunction due to long CPB, or maybe inappropriate myocardial protection during CPB, leading to low cardiac output state, or to start with, failure to wean from CPB. In all these situations, there may be a role for there may be role for ECLS or the ECMO, pulmonary hypertensive crisis, refractory bradycardia. All these situations, ECLS should come as an extension of post-operative resuscitation. And one should always consider ECLS or the ECMO after the second dose of epinephrine. And usually, like you see in the picture on the right side, Like you see a picture on the right side, central ECMO is preferred in neonate with an open sternum, and sometimes a carotid cannulation is performed to make it easy. And in the last slide, the posterior resuscitation care. It is important once the resuscitation is done from the cardiac arrest, maintain normal perfusion, maintain oxygenation, normothermia, so that there is no recurrence, and then talk about treating seizures that which could be due to hypoglycemia or hypoxic seizures, maintain normal metabolic milieu, correct the electrolytes, renal perfusion, nutrition, urine output, and then maintain hematocrit and take care of the electrolytes and sedation as required. This is our experience. These are some common situations which we have faced in the last 1 year where the neonate was brought into the cath lab, 13, 14 situations, where you can see there are certain emergency procedures, some elective PDA stenting done for, let's say, tricuspid atresia with the PDA dependent circulation, or PDA stenting done for systemic circulation. And then on the right side, we've done about 11% of neonates in the entire cardiac surgery population over the last 2 years. So the take-home message is that neonatal resuscitation in OT is usually witnessed and reversible. That is more important to understand. And they are a high-risk population. Heart rate dependent cardiac output is the dictum in neonates. So bradycardia is as good as a cardiac arrest. Circulation takes priority. Treat other causes like hypoglycemia, hyperkalemia, hypothermia. They become very important. Chest compression, like I said, tooth, thumb, chest encircling technique is important. And since the patient is intubated most time, ETCO2 can be used as a good marker for effective CPR and also ROSC. And duct-dependent lesion, not all cyanosis can be treated with more oxygen, and early ECLS should always be kept in mind. These are my references. Thank you.
Thank you, Dr. Bhargava. That was a lucid talk. We'll come to any questions in the end.
Yeah.
Now we'll go to the
Thank
next
you, Dr. Bhargava, for your visit talk. Now I'll speak, invite the last speaker, that is Dr. Veena. She's our assistant professor of cardiothoracic surgery in Chitra. She did her MCH from Kottayam Medical College, and she's having 3 years experience after MCH. And she has publications in JTCVS, 2 very important publications in JTCVS, and also in International Journal of Surgery. She's a very dedicated cardiac surgeon, and as usual with all cardiac surgeons, especially pediatric cardiac surgeons, she spends a long time in the cardiac OT and ICU, and actively involved in the patient management. So may I invite Dr. Veena to speak on the prophylaxis and management of infections during perioperative neonatal cardiac surgery. Dr. Veena, please.
Yes, sir. Am I audible, sir?
Yeah, you are audible.
Thank you, sir, for the generous introduction. Is it visible, sir? I hope it is visible.
Yeah. We can see the slides.
Okay, so my topic is prophylaxis and management of infections during perioperative neonatal cardiac surgery. So let me start by just mentioning about World Sepsis Day. It was celebrated last year in September 13. Every year celebrated on September 13. And last year's the theme was infection prevention saves babies' lives. So I thought I would put this slide because it is relevant to this presentation. So when we talk about when we talk about healthcare associated infections, they can be urinary tract infections, that is then surgical site infections, central line associated bloodstream infections, ventilator associated pneumonia, Clostridium difficile infections, and hospital acquired pneumonia. And although this is a very broad classification, but the same thing almost applies to pediatric patients, especially neonates. Now there is a simplified, this is taken from textbook, and a simplified criteria for surveillance of nosocomial infections. Now surgical site infection, any purulent discharge, abscess or spreading cellitis at a surgical site. Urinary infection, positive urine culture with at least 10 to the power 5 bacteria per ml. These are just general definitions which we all know and which are applicable to any surgery or any hospitalized patient, and respiratory infection, vascular catheter infection, and septicemia. Now, so when we first let me discuss about surgical site infections. Uh, uh, the major pathogens which are involved in surgical site infections are Staphylococcus aureus, which is 32% of the cases. Then Coagulase negative Staph aureus, Coagulase negative Streptococcus, then Pseudomonas and Klebsiella. Coming to the epidemiology and risk factors of this surgical site infections. Now, various studies have been published in various journals, and the most common thing which they have found is that age less than 30 days has a high impact of surgical site infections. For example, neonates are more prone if they are more prone than older infants. And in a study of 283 neonates, there was found to be 6% surgical site infections. And if the patient has undergone delayed sternal closure, it increases risk of exposure of the sternum of the wound to gram-negative organisms like coli, Klebsiella, and the Pseudomonas. And in various studies, it was found to have 4.5 times more risk for prolonged hospital stay. And if the procedure has been long, that is, if it is a complicated surgery and the CPP duration is more than 120 minutes, again, this impacts the risk of infection. And the child is low birth weight, then again, it is another significant risk factor for infection. Now, in 2010, Bhargava et al. Published a study in which they found that the same thing which I have mentioned before, young age, high complexity, previous cardiothoracic operation, preoperative, stay for more than 1 day. That is, if the patient has been admitted in the hospital prior to operation for more than 1 day. Then preoperative ventilator support, if the patient has been already intubated, and presence of significant factors. And the study showed again prolonged ventilatory support more than 2 days, hospital stay more than 2 weeks, intensive ICU stay more than 3 days, and if the patient has undergone a reopening, especially in the ICU, or there has been an extubation failure, then there's an increased chance of infections. And also excessive blood loss within 24 hours after surgery also was associated with surgical site infection. This might be, the theory is that it is related to the age of the transfused RBCs. Now, in the preoperative period, how we can avoid infection post-operatively. First thing, it starts in the preoperative period itself when patient is admitted to the ward. First, screening for nasal MRSA, and as a part of prophylaxis, mupirocin ointment can be used, but usually it is avoided in small children. So what we do is chlorhexidine wipes can be used for small children preoperatively. And pre-incision, the recommendation is to give cefazolin IV before 30 minutes before the incision, and vancomycin if the patient has a risk of MRSA. Other important thing is that the blood sugars should be controlled during intraoperatively as well as postoperatively to avoid the chance of infection, and normothermia should be maintained. Now, inside the theater, the cefazolin should be redosed at 30 mg per kg every 4 hours if the procedure is more than 4 hours, or on CPB. If the CPB is likely to be over within 4 hours, then the second dose of cefazolin can be held up till after the CPB is over. And another thing is that strict asepsis should be followed during the procedure. Laminar flow in the operation theater is usually preferred. And if the patient is on ECMO, then circuit disinfection is advised with chlorhexidine or isopropyl spray. The most important thing is clean hand hygiene with alcohol rubs before touching the patient, after touching the patient, and before any procedure. It has been shown that once these infection bundles are, if they are compliant, and if compliance is more than 90%, it reduces the chance of surgical site infections. Now, management strategies. Once the infection has occurred, how do you manage? Standard prophylaxis, I have already mentioned that cefazolin is the drug of choice at neonatal dose of 30 mg per kg, twice daily. Then timing, it is given usually less than 1 hour pre-incision, most 30 minutes pre-incision, and repeated 48 hours post-op. If it is a closed term, and the drug doses are adjusted for renal function if CPB time is more than 2 hours. And vancomycin, if the patient has a risk of MRSA and if it is open sternum, then the neonatal dose is 15 mg per kg IV, 12th hourly or 24 hours. With cefazolin, 24 hours post closure. And again, levels are to be monitored. Then gentamicin is added if the patient has an open sternum and or if there is a gram-negative infection at a dose of 4 to 5 mg per kg IV every day or 48 once in 48 hours, along with vancomycin to maintain a trough concentration of 1 microgram per ml. Again, this has a high risk of nephrotoxicity, so the dose has to be adjusted accordingly. If the patient has beta-lactam allergy, then we have to avoid cefazolin and use clindamycin instead at 10 mg per kg IV, A6 hourly or 8 hourly as an alternative. It also covers anaerobes. Now, for neonates less than 7 days or if there is an open sternum, cefazolin can be paired with vancomycin 15 mg per kg plus gentamicin 4 to 5 mg per kg if there is a gram-negative risk. Now, diagnosis is by superficial, if it can be superficial infection or a deep infection. Superficial infection, usually there will be erythema or a mild serous discharge from the wound. If it is a deep infection, there is more chance likely to be involvement of the sternum with a rocking and continuous serous discharge and fever more than 38 degrees Celsius post-operatively, mostly from the day 4 or 20. Then cultures can be sent after that mostly from the culture swab from the wound. If there is suspicion of mediastinitis, cultures can be sent from the drain fluid, as well as mediastinal swabs when the sternum is open for re-exploration or mediastinal wash. Then imaging with CT MRI can be done for mediastinitis if it presents after the patient has been if there is a suspicion for mediastinitis and deep infections. An echo can be done to rule out endocarditis. Now, management of such infections is empirically we can start vancomycin or piperacillin tazobactam or meropenem. Mostly it is tailored to the cultures, and surgically thorough debridement of the wound along with vac therapy, vacuum assisted closure is required. It is preferred to keep the wound with daily dressings if there is an active infection. But if there is if the cultures haven't grown anything, then a vacuum assisted closure may be preferred. And once the wound is granulated enough, then a rewiring can be done if it involves a stone. And even cases the patients have to be put in ECMO sometimes if the sepsis is too severe because a severe cardiac dysfunction. And usually it involves multidisciplinary team involving the microbiologist, the infectious disease department, and the surgical department as a supportive care. So this is just a gist of what I have told earlier. Preoperatively, chlorhexidine bar. Intraoperatively, antibiotics half an hour before the incision. And thorough skin preparation with chlorhexidine or betadine. And intraoperatively, surgeons after incision must change the surgical gloves or before the surgical procedure. And intraoperatively as well as postoperatively, the glycemic control, use of prophylactic antibiotics, and thorough inspection of the starting 48 hours postoperatively when the dressings are removed, and early detection of any infection so that adequate treatment can be started. Now, central line associated bloodstream infections, predictors are younger age surgery. This is just quite general. Greater surgical complexity, lower oxygen saturation, post-operative ventilator usage more than 2 days, central line usage more than 4 days, and whether it is before the preeclampsia bundle period. Now, the crux of every infection prevention is hand hygiene, and for which chlorhexidine can be used. The hubs of all lines should be scrubbed properly, and before any manipulation, hand hygiene should be undertaken. All lines should have a full sterile barrier, and should be inserted only after chlorhexidine screen prep. And optimal catheter site, that is for adults, are selection in adults as well as children. And dressing and disinfection of all ports before taking any samples for ABGs, VBGs, etc. And any soil dressings should be changed immediately. Uh, and timely removal of unnecessary catheters. This is another important thing. Just if there are not lines, each of them, each point of entry into the patient is a point of entry for infection. So whatever is not necessary can be removed as the patient is stepped down on the treatment. This is hand hygiene for before touching a patient, before a procedure, after touching a patient, and after touching patient surroundings. Now, measures for prevention of infection, I have already mentioned. The urinary tract infections, the proven measures are limited duration of catheter, aseptic technique at insertion, and maintaining a closed drainage. Now, if a urinary tract infection does occur, mostly it can be uncomplicated or complicated UTI, which is UTI along with sepsis. Mostly, if it is uncomplicated, usually give nitrofurantoin 5 to 7 mg per kg per day in 4 divided doses. And Klebsiella, if there is a Klebsiella or Enterobacter proteus infection, oroceptran can be given. This is for older children. And if it is in a younger child, for complicated UTI, we prefer amikacin or IV piperacillin tazobactam. Now, surgical site infections I have already mentioned. As far as pneumonia is concerned, for ventilator-associated pneumonia, usually it's due to microaspirations and due to mostly caused by gram-negative organisms. So, injection piperacillin tazobactam at 100 mg per kg per dose 8 hourly can be started. And after the endotracheal cultures are reported, the antibiotics can be changed accordingly. But if it is ventilator-associated pneumonia with sepsis, IV meropenem is a choice of drug. Is the drug of choice at 20 to 30 milligram per kg. Now, regarding surgical site infections, for mediastinitis, again, it is usually caused by gram-negative organisms. So, IV meropenem and IV amikacin is a drug of choice for that. Again, this is just a repetition. Strategies to reduce hospital-acquired infections, triggers hand hygiene, enhanced sterilization, isolation practices, preferably in a chamber with laminar flow, so that the child is adequately isolated. And antibiotic stewardship programs to be maintained, and staff training as well as regular audits to be done to prevent infections. Thank you.
Thank you so much for that lovely talk, and I'm indeed grateful to the speakers, Dr. Gayathri, Dr. Diana, Dr. Bhargava, and Dr. Veena Vasudev for that excellent exposition of the topic assigned to them. Thank you so much. And I request all the panelists to switch on their videos and then go through the chat box, and then any comments or any questions are welcome.
I think Vaikar sir has asked some few questions.
Is it? Yes.
Yeah. So, laryngospasm, most effective treatment is administering. I think this is for Diana Mosoli. Most effective treatment is administering just 2.5 to 5 milligram of suxamethonium. Fentanyl rigidity treatment is to give muscle relaxants ASAP. Any question in that, sir, or just a comment?
It looks like a comment.
Like a comment, yeah. And the next comment is to reduce the priming solution in neonates, one important alternative is to place CPB machine behind the operating surgeon rather than in front. In the Great Ormond Street Hospital, for kids in London, sometimes they use this technique. Albumin is preferred as a priming solution. Yeah. So basically, I agree. To reduce the priming volume is very important in neonate. Even retrograde priming also is practiced routinely in our place. Is Gayathri there? I have some
Yes,
one question to Gayathri.
very much
Yes,
there
sir.
is.
See, usually in our institute, the surgeons in neonates won't prefer to give FFP
Yes, sir.
because they believe that it will cause more dilution of the coagulation factors. I would like to know from Keshav, what is the practice in Narayan Hrudayalaya? Do you, in neonates, do you administer FFP routinely, or you restrict to the cryoprecipitated and platelets?
The routine practice is only keep the hematocrit around 35 to 40 in the post CPB period. Unless we find there is clinical evidence till around, though there is so much of, we don't do heparin levels to administer protamine. So, but 2 to 3 doses of protamine is given, and only if there is an still we find that there is surgical bleed, or there is area is looking very oozy, then we ask for cryoprecipitate or platelet. More first, initially, the preference is to give some platelets, but except for a arterial switch operation, even TAPVCs and all, we don't use anything except packed cells.
So you strictly avoid
Yes,
infusing the platelets.
all of those things, FFP, plate, cryo, everything is avoided. We just try to keep the kit around 40, and we are able to do it with that. And as I said, I know it may be against the dictum, but still, the problem is they would have added heparin in the pump also. So we do give second and a third dose of protamine before jumping to blood transfusion, because it is less harmful when compared to starting blood transfusion or any of the product transfusion. Product also in between, we used to have a little more of platelet or cryoprecipitate transfusion when the surgeon was using 6-0 for switches. But after they switched over to 7-0, there is hardly any needle holes bleeding much. And before the PA anastomosis, if the aortic reconstruction is taken care with extra stitches, you, except giving some 15 to 20 ml of Paxil, you don't land up giving anything.
So I think you're strictly following the international guidelines, avoiding platelets. And what
Yes,
about the use of
sir,
Rotem?
I had always had the problem. Those who were trained in US, UK surgeons, and those who trained in Australia, when they came, they immediately start jumping that no, we have to give platelets because that is damage, that is this thing. So I've always told you, just wait. We'll see if it is required. We'll transfer. Otherwise, no. So
No, so you
slowly
do
they come to our route, because the dictum there is that it is damaged, you have to be transfusing or whatever it is. I have not seen them, but only heard from those surgeons that yes, we give platelets. Even one Australian surgeon who is working with us now used to jump that we used to just give factor 7A and close the chest and send the patient. But the same factor 7A which we gave in our
in
patient.
neonates, did they give neonates or
Yes,
older children?
yeah, in neonates, and little bit bigger one, like 2 months, 3 months, when you have done a complex surgery, we have found that lot of thromboembolism afterwards, and the surgeon himself calmed down that we are not using that factor 7A. I am
Yeah, because the evidence goes against routine use of factor 7A, and
yes,
even
it's all just out of the book, but practical experience has shown that we have had enough cases of arterial thrombosis, etc., with factor 7A, and we have stopped using that.
Sure. Can we go to the next question? Main cause of delayed sternal healing is the use of diathermy, especially periosteal areas, and use of bone wax which remains in situ permanently. Dr. Veena should address this question.
Yes, sir.
Use
So they have,
vancomycin or etc. What's written there?
yes, sir. Sir, there are studies which have proven that bone wax, there proven studies that bone wax is delays bone healing. So, if if the sternum is primarily closed, usually the use of bone wax, if the sternum primarily closed, it doesn't cause that much infections post-operatively. But in a patient in whom delayed sternum closure has occurred, if the bone wax is still persisting, it might act as a nidus for infection and cause a sesae post-operatively. So what is done is while closure, the bone wax is removed with the help of a scoop, and then only the closure is done. And mostly the cautery is kept very minimal, and only bleeding points are cauterized rather than just buzzing off everything. So more tissue damage means more thermal injury and more chance of infections post-operatively.
Thank you. Thank you for that response. The next question is, any specific alterations one should adapt while resuscitating a patient after Fontan operation in post-operative period to have an effective outcome in addition to conventional CPR? This is
Sir,
to Bhargava.
Bhargava, yeah, for
Yeah,
Bhargava. Yeah.
Bhargava.
yes, sir. So, spontan, sir, is a tricky situation, we all know.
Yeah.
The usual chest compressions are not supposed to be very effective, primarily because there is no subpulmonic ventricle. So when you compress the chest, you expect that the cardiac output is going to increase. Some amount of cardiac output is going to be there, but that is not happening. One, primarily because the intrathoracic pressure is increasing, the venous return is not going to improve. At the same time, there is positive pressure ventilation. So the basic dictum is to keep the PVR reduced with the lower pulmonary PVR with the lower tidal volumes, reduce the PVR. And conventional CPR is the one which is done, and early ECLS is recommended with the return of any rhythm. But there have been studies or some videos, some literature, some fancy studies also talking about abdominal compression alternating with chest compression. But there is no effective evidence conclusively which talks about the effectiveness of this abdominal compression in cases of Fontan. So, one primarily from what I've read is that it increases abdominal pressure and also hepatic congestion, and that abdominal pressure is transmitted to the thorax. So effectively, there is no increase in venous return, although it may appear intuitive that abdominal compression might increase the venous return into the chest. So the best thing is to restore rhythm and go for early ECLS, I mean the ECMO. In our situation, we had one Fontan. Unfortunately, in the post-operative period, the same evening, around 7:30 in the evening, she suddenly developed arrhythmia and went into VT, which could not be revived. So we shocked. For everything went off okay. We were maybe in the next half an hour we would have extubated, but unfortunately she threw up VT. We shocked, gave amiodarone, everything, nothing worked. We did a echo and we found that it's just a VT, then nothing is moving. So immediately sternum was opened and we put on ECMO. But unfortunately, the neurological damage was too much. Probably by the time we started the ECMO and all, he did not survive, but the point is these are very unforgiving situations like Fontan arresting post-op.
Right. Actually, there's a question on you have this CALS for adults. Do
Yes,
you
yes.
have such thing for babies?
Sir, I specifically look for it. CALS for adults is very well documented, and even in the, I think, Nagpur, there was one workshop, pre-operative
Yes, yes.
workshop, pre-workshop, I mean, pre-conference workshop on CALS. Very impressive, but specific to that for cardiac surgery is not available. But there is one Singapore-based guideline called Perioperative Pediatric Life Support (PPLS), which they train anesthesiologists specifically and pediatricians for perioperative pediatric life. It is called PPLS, and the agency is from Singapore. that is there. But specific to cardiac surgery, like CALS, is I don't think I looked up specifically for this. Once I found the guidelines for adults, sternotomy, emergency sternotomy. Maybe seniors could throw more light on
Dr.
this.
Sonali, you want to say anything on this? You'll have to unmute and say. Is there a recommendation to open the chest immediately if
Sure.
there's assist in babies?
Uh,
As in adults, we need to open the chest as soon as possible.
yeah. So again, I've been practicing only adult anesthesiology, so I apologize in advance. I don't have much experience in on the top pediatric cardiac surgery. Apart from my residency training, I haven't practiced. So I work in adult critical cardiac care, and there is this protocol which was actually developed in United Kingdom. And the crux of this is, and this is currently, as Dr. Bhargava mentioned, is probably just for adults. So the crux is the commonest etiology when a post-op cardiac surgery patient arrest is two etiologies. One is ventricular fibrillation, and second is mediastinal bleeding causing pericardial tamponade. And that's the reason the regular AHA, ACLS algorithm was tweaked. So normally when it's a shockable rhythm, you normally give one shock and then you start your CPR with chest compressions. Whereas here it was advisable to do 3 stacked shocks. So the purpose is to stay a little bit away from jumping on the patient's chest, because what was known was the right ventricle, which is right under the sternum. During the chest compressions, in fact, we could cause more damage. There are reports of having right ventricular rupture, or sometimes the bypass graft is running right under the sternum. That can have issues, sternal dehiscence, the valvular apparatus can have dehiscence. So that was one. And then in terms of an asystole or severe bradycardia, use your epicardial pacing wires first, again, before jumping onto the chest. And if there is a ventricular fibrillation, the consideration was to disconnect the epicardial pacemaker to see if there is an underlying rhythm and then accordingly treat it. So the protocol was tweaked. We adopted that in our university in Southern California. And it's already there out by Society of Thoracic Surgery. There is general consensus and there are guidelines, but this is all for adults. I wasn't aware. I was just curious if there is anything in pediatrics.
Yeah. I had the same question in my mind. We have the CALS for adults where you're supposed to open the chest immediately after doing a couple of shocks, as is mentioned in the algorithm on the left-hand side of the slide. So apparently there is none, as Bhargava was saying. Bhargav, do you want to respond to
looked
that?
for it, sir.
No.
I could not find anything specific to pediatrics. Only
Pediatric,
thing
yeah.
that I found specific for pediatrics is this one, neonate.
Right.
This is also recent publication in a neonatology anesthesia journal.
We see Adanapudi's name there, so it's
Yes.
from India.
In 2023, it's a review. It was not evidence based or anything. Neither a systematic review. It was kind of an opinion paper, I guess.
Sure.
Of opinion than anything.
Thank you. I request Dr. Rupa and Srinivas, Keshava to take other questions which are in the chat box, and then we'll see how it goes. There's one question.
Dr. Hassan, he says, what criteria should guide us to stop the resuscitation in neonates? Because there are cases whereby resuscitation was prolonged and patient recovered with no neurological sequelae. So is there any time limit? Basically, he wants to say at what time we should stop the resuscitation. Bhargava would like to answer, or?
Yeah, it is for Bhargav. Yes.
Sir, I am not so experienced to talk about this.
So what I understand, the recent guidelines, 2025 guidelines, they have given general guidelines.
Yes.
They said 20 minutes is the time where you should really think whether you should continue CPR or not. But again, in cardiac surgical patient, pediatric cardiac surgical patient, the criteria may not be suitable because we have all monitoring in place, and the patient is already in the ICU, maybe on ventilator. So possibly the outcome of the resuscitation may be very good. Like in our ICUs, we resuscitate the patient for more than an hour. And still I have seen some of the patients who went on ECMO, they could make it, they went home Our first ECMO child, I remember, after more than 1 hour resuscitation, we put on ECMO and the child survived. So possibly, I'm not very sure whether any time limit is there for the pediatric cardiac surgical patients specifically. For general, they have described 20 minutes. You should really rethink and take the opinion of all experts and especially the family to discuss with the family. But for cardiac surgery, I think I haven't come across any such specific time period.
Sure, sure.
Since the threshold for ECMO is low in post-cardiac surgery patients, probably there's no time.
One question for Dinah. Dinah, you said 95% of your patients after extubation receive NIPPV.
Neonates, only neonates, huh?
Neonates, yeah.
Yeah.
And 95% neonates, sorry. And 5% you go what CPAP or maybe high flow. So what about the role of high flow? Because some of the studies, recent studies have shown that high flow is actually in some way it is more effective than the trauma. The trauma because of the interface is much less with the high flow. And it is accepted by the patients much easily. The feeding is much better with high flow, especially if your patient is requiring non-invasive ventilation. Second thing you mentioned that you use a long nasopharyngeal airways for. Is it again accepted? Because they say the neonates are usually breathing nose breathers. So if the 50% of the nostril is occluded, they'll need some time to get adapted to the new situation because of the high position of the tongue with respect to palate, and also the epiglottis also may be at a high position. They may not be able to breathe through mouth very easily. So are they comfortable with high airways? And second thing, what about the role of high flow nasal cannulas or oxygenation?
If this is from our experience, sir, we actually do not use high flow nasal cannula routinely. We use it only mostly our situation is when we have a child extubated to NIV, and then we are dependent on NIV for a very long time. We're not able to wean him off NIV. Then we transition through high flow. That is our usual scenario. We do not use it as a first choice in the immediate post extubation. Unless we do not have much, we do not suspect extubation failure or anything, then we might transition through HFNC. Otherwise, the routine has been to use only NIV. It does cause less less risk and injury to the airway. But what we feel is a positive pressure. Like I said, we usually extubate all these neonates in a slightly sedated plane. They're not very vigorously active or anything. We want to avoid pulmonary hypertensive crisis. And even after extubation, there might be times when they might start crying and we will have to go up on sedation. So in such situations, using high flow or a nasal CPAP are riskier than having something that will intermittently give a positive pressure ventilation. Then there are some advantages to the method that we use, that we are able to clear out the nasal pharynx, the deeper areas of the nasal pharynx better when we have a patent nasal tube in. We do not have evidence for that. This is from experience again. This is what we have felt. Then what is your question about? Yeah.
We also have tried the longer nasal airway, nasopharyngeal airways. But then the acceptance of the children was not that, like they were not very
We find it, the older children don't, sir, but the neonates, we
neonates.
do not have a problem actually. We find them comfortable on that. Maybe the initial, when we put it in, it might be a little difficult, but
What
then
about
they
feeding?
settle down.
Feeding,
Feeding, we
is it
always
advised?
have an NG tube. We always have an NG tube. We go up to full feeds, even on an IV.
Dr. Gayathri, you mentioned about Jehovah's Witness. Do you have any experience with Jehovah's Witness in neonatal cardiac surgery? And if yes, so how did you manage that?
Till now, no, sir. In cardiac surgery, I've not met, but in general pediatrics, I've met one patient. But fortunately, that patient did not bleed much and did not require a transfusion.
Super. That's great. How do you fix CVP catheter to prevent infection? This is to Dr. Veena, I guess. And do you sutures? What's your advocacy on this? Dr. Veena, are you there?
Yes,
Or
sir.
there's a question on how do you fix the CVP catheter? Sutures or non-sutures?
Yes, sir. So we actually fix with sutures to the snugger itself.
Right,
It
right.
is a CVP catheter.
CVP catheter, this CVP.
We fixed with sutures, sir, both of them, and then stick an offsite on top of it. Take a
Right, right. There's one non-academic question. I don't know what it means.
That is regarding the picture of Dr. Veena.
No, sir. That's someone else's
Microsoft
laptop.
wants to know what it is.
It's a picture of Batman, but this is not my laptop actually. It's someone else's. I couldn't connect mine. So
Sir, regarding the HFNC, if I may add.
Yes.
So in our situation, in our scenario, all babies under 5 kgs and generally less than 6 months patient, most of them, it is 100% they go for HFNCs post extubation. And if required, they'll be weaned off HFNC by the next day morning. But as a default, we generally tend to go for HFNC. One is for as a protocol thing. Thing is that there's a lot of convenience in terms of using HFNC. You can feed the baby. Child is able to interact with the mother. You can give the baby to the mother probably after extubation within few hours. We've stopped using the nasal CPAP, the RAMS cannula, and all those things. It's becoming, and evidence also supports the same. But the only point of contention is using the nasogastric tube along with the HFNC. When you have HFNC and you also have the NG tube in place, there's a lot of objection. There's a lot of interference because the nasogastric tube, whether it will work or not. Sometimes we put an oral one, but there's a lot of secretions. So that is one thing. We go up to half each, and we monitor particularly what is known as the ROX index, which is proven in adults and in chronic in patients on HFNC, where SpO2 by FiO2 divided by respiratory rate. So if it is more than 4.8, it is supposed to be normal. That is the ROX index that is used. So we use that commonly even in children, and that works well for monitoring on HFNC.
I think its a role is between non-invasive ventilation and the ordinary oxygen mask.
Conventional oxygen. Yes.
If you think that NIV is enough, but okay, and the mask is ordinary oxygen mask is not enough, then there comes the role of this. Regarding that fentanyl and rigidity,
Yes.
if you are planning to use a high dose fentanyl, then you can prevent rigidity by pre-cauterization.
Yeah.
Once a child is knocked up with a bit of sevoflurane and some other injection drug, and before you give the full dose of fentanyl, you can pre-cauterize. A touch of pre-cauterization helps to prevent the rigidity, not only in neonates but also in adults. Now, I'm glad to see that transfusion decisions are moving away from single hemoglobin triggers.
Mm-hmm. Yes.
I think Dr. Sridhar wants
Bhargava, one comment about what you mentioned about your study. Most of the literature mentions that NIPPV is the best way of going for non-invasive ventilation in the immediate post extubation in the neonate. The main reason being it depends upon what is the status of the respiratory and especially the oxygenation index and the FiO2 to PaO2 to FiO2 ratio. Especially these factors are worse in the early period. If the patient preoperatively is having history of failure or preoperatively he had history of severe pulmonary water logging because of any reason, maybe shunting or was on ventilator. So this second thing is many of the children will be sedated immediately after extubation. So they will be better maintained by the NIPPV because NIPPV will not only reduce, it will maintain the gas, it will maintain positive pressure, which will recruit the lung better than because it will generate more positive pressure in the airways. which will maintain the airway dilatation also and recruiting the lungs also. That is, FRC will be better. Gases are better. Both oxygen as well as CO2, both will be better managed with the NIPPV than the high flow. High flow is good for oxygenation, but for CO2, it may not be much good. So,
Sridhar
if
wants to say
children who are tend to retaining CO2, have tendency to retain CO2,
yes,
or
yes.
those who are in type 2 failure, respiratory failure, possibly maybe when. So here also in Chitra also most of the children will go for NIPPV after extubation because many of them will be drowsy, just recovering from the anesthetic effect. And as Diana mentioned, we too practice most of in the same way. Like those children who are on NIV for longer time, these children will be put to high flow. But theoretically, the disadvantage of NIV is that it will increase the work of breathing because CO2 clearance will not be very good with the NIV because
That
it is
is
the
what I
approach that
wanted to ask.
yeah.
What is the level of your CO2s when it is patient is sedated and you are put on this type of ventilation? Because what we have seen is on-table extubation with mix ASD, VSD, and coarctation cases. We find that the PCO2 in the postoperative period, because Dexam is going continuous infusion, these children have a PCO2 of 55 to 60 many a times. And then you feel, is it required that the sedation has to be reduced to a certain extent so that the CO2 stimulatory effect on the respiration is there?
No, actually, what I find is that many of these children with left to right shunt, say ASD, VSD, or ABCD, once first 2 or 3 blood gases will always show high PCO2. So we electively increase the ventilation more, something about 125% of the what it was preoperatively. And then the postoperative PCO2 may be normal level. It's a very, I think possibly it's because of changes in the pulmonary blood flow, acute changes in the pulmonary blood flow, to which the body is not used to. So this observation, common observation that all the children with ASD, VSD, and the AV canal defects, the immediate postoperative period will have high PCO2. Still yet to know exactly, but if you ventilate in a normal fashion, they will get high PCO2. So after extubation also, as you mentioned, maybe somehow they are getting dexmed and other sedatives. That may be one of the reasons why PCO2 may be going. But even on ventilator also, the PCO2 will be high if you ventilate them in a normal minute ventilation.
Yeah. The explanation there is that the pulmonary dead space increases because the pulmonary artery pressure comes down and there is more space in the alveoli to expand. So the dead space effect increases. So you have to ventilate a little more than what normally you would do immediately just after surgery. But Dr. Keshava, this thing is after extubation PCO is 55. I think that is a common thing. Up to 55, I think we should not worry about it as long as patient is otherwise stable and breathing well. 55 should not be a reason for reintubation. Sometimes the intensivists think that it is high and they start to intubate, but it's not needed. It's very rated.
Many of them will have alkalosis, baseline alkalosis also, especially they are on heavy diuretics.
Yes.
So sometimes they may retain the CO2 in the postoperative period.
Yeah,
Dr.
that
Sridhar
happens.
wanted to make some comment.
Yeah, that happens in mitral valve disease. If they have metabolic alkalosis, they will CO2 will be retained. Sridhar, you want to say something?
Yeah. Good evening, sir.
Talk after that.
Yeah.
Welcome, Sridhar.
It's a good evening, sir. The specific point about sutures used for CVC, I think it's a very important point. I stumbled upon a few papers regarding this. So silk has been known to be braided and it is a nidus for infection in many places. Since silk has been stopped to be used in subcutaneous and in intracardiac cavity suture lines, there was a question, why should we use a suture line made of silk for central line suturing as well, because that itself is a nidus of infection. So there's one school of thought of using proline for this as well. I'm really not sure if there is significant evidence for it. That's something thought we should take home today, as to is there a role for proline for suturing central lines, which might reduce harboring skin bacteria onto the suture line, and will it reduce central collapses for per se. That's
Sure.
one point I wanted to make. Second point, coming to the CALS in peri-neonatal period, cardiac arrest, post-neonatal cardiac surgical scenarios. In our setup, we use almost the same adult CALS that is used in the adult scenarios for cardiac arrest after cardiac surgery. Is the same one. The fibrillation, you try 3 defibrillation shots. In the meanwhile, prepare chest open. Most of this is in the acute post-operative period, day 1, day 2, that we commonly utilize this protocol. Day 3 onwards or post-extubation onwards, scenarios change a little bit. There's no clear-cut dictum on that scenario. But for the first and second days, till the kid is likely ventilated, a cardiac arrest is considered as a pericardiac surgical cardiac arrest, and we routinely follow what is mentioned in the CALS as well. The 3 defibrillations for VTVF, atropine and pacing for the bradycardic arrest. Consider chest opening, internal defibrillation, internal cardiac massage, and ECMO. These are the routine rough guides on which we follow our cardiac surgical cardiac arrests. The third point I wanted to add on was the NIV versus high flow. There's one specific aspect I wanted to add here is single ventricle physiologies. The positive pressure ventilation which the HFNC brings versus only reasonably lower positive pressures which the high flow brings makes an impact on this particular group of patients, that is single ventricles. So there is a tendency to use the high flows more than the HFNC scenarios or the CPAP scenarios. Bubble CPAP has helped significantly in this particular group of patients. So this is a point I wanted to make, sir. Thank you.
So your points are well taken. I just want to know if the patient had minimal access surgery done, suppose ASD or whatever, do you open the sternotomy or how do you open the chest if this arrest?
Thanks for that question. Thankfully, we haven't faced that in the last 200 odd cases.
No, that
But
option
whenever
must be
there
there.
is a scenario there, we
Can
have
I intervene, sir? There are few occasions where the patient was in the theater, thoracotomy was done, and case was going on. And when the patient is arrested, many a time, most of the times, it is the midline sternotomy which is done afterwards. I had an experience with one ASD being done, and the patient developed a massive pneumothorax on the other side. How that happened, God only knows. But then the patient decompromised because the closure was on. Then immediately when the sternum was opened, they found that that pleura was right into the right side. And then they have to just test tube opening that pleura itself helped. But so far we have not faced with pediatrics one, but few of the occasions, especially with minimally invasive cardiac surgery with CABGs, there are situations where they have opened the sternum.
One question regarding this blood transfusion is cyanotics. Usually, what is the policy adopted? Because there are no guidelines published for blood transfusion in cyanotics. So usually what we do is, usually the patient comes with a hemoglobin of something about say 18 or 19. After CPB, we maintain the higher hemoglobin, more than 15 plus, 15 to 16 hemoglobin, maybe 2 to 3 grams less than what it was pre-op. Because what we found is that if you keep very low hemoglobin, when the patient started with hemoglobin of 19, 20, if you maintain hemoglobin of 12 or 13, they usually, their parameters are not very stable, hemodynamics as well as the lactate and will rise. So what policy is adopted in other centers? I'm interested to know. Because there are no guidelines published.
I wrote down this point and kept it to be discussed. Most of the times, you go on bypass and come off bypass, the hemoglobin drops by around at least 3 grams %. And then the dictum will be to see how the hemodynamics is maintaining, especially with BDGs and Fontans most of the times. Then though you have a hematocrit of 40, 45, you may not find that the heart is full and means the adequate preload loaded. And then you may find that the pressures are on the borderline of around 80 or 90. So then invariably, most of the times, if they then plan to give FFPs for volume, again hemoglobin is going to drop. Have landed up giving one Paxil before the FFPs are infused, because there again your hemoglobin is going to drop if you start giving FFP early. And the other point about this hemoglobin drop was when you, sorry, I forgot the. So we usually give blood only if there is associated hypotension, and if you find that the lactates are also most of the times on the little higher side, because these were on quite a good amount of anaerobic metabolism was going on in the body.
So how much hemoglobin will you accept? For example, if hemoglobin baseline is about 18 or 19, of course,
at least around
neonates may
15.
not have so much.
Yeah, it will be around 15 when we come off bypass, and we need to
Okay.
maintain with that.
Okay.
The other thing is, because hemoglobin is more, you try to do preoperative blood collection in the OT itself.
Yeah.
Find that most of the times on CPB, your peripheral vascular resistance is not adequate, and the mean perfusion pressure will be somewhere around 30 or 35, with good amount of collaterals also being AV collaterals being there in the patient. So we don't preoperatively collect blood from any of these patients, even if their hemoglobin is 19 or 20. On bypass, the perfusion is, if he finds the pressure is good and still the hemoglobin is high, they start collecting it in bags and add that back when we rewarm and try to come off bypass.
One question for Dr. Veena. Many patients preoperatively are admitted in the ICU. Some of them will be on ventilator, or some of them may be just receiving NIV or even oxygen. So when they come for surgery, many of them will have some kind of infection. Their procalcitonin will go up, and they may have received antibiotics. So are there any guidelines regarding how to screen them in the preoperative period? I try to search, there are no guidelines. We are just going by the parameters. Are there any published guidelines regarding the preoperative screening of the patients who are admitted in the hospital, especially in the ICU, who are either on ventilator or NIV, or those who are without any, just on oxygen, but those who are admitted for significant period when they are coming for surgery?
Sir, as of now, there are no published guidelines for neonates as such. But what we follow here is we usually do a procalcitonin when the patient is admitted, or maybe if we are when we are planning surgery, 2 or 3 before that, days before that, we do a procalcitonin. Usual values are less than 0.1 nanogram per ml. If it comes less than that, then we usually less than 1 nanogram per ml. If it comes like that, then we accept for surgery. But if the patient has a high procalcitonin, more than 1, then usually we ask to send all the blood cultures, urine cultures, and if the patient is intubated, endotracheal tube cultures. And once those results have come, then we empirically start the patient on piperacillin tazobactam. And once the culture results come, we start on the appropriate antibiotics. And usually the recommendation is to do a PCT every 6th hourly or in every 24 hours before starting an antibiotic if we are just monitoring. But once the antibiotic is started, the recommendation is to do it 48 hours, 1 or 2 days, to repeat it every 1 or 2 days and see the trends. So if the PCT is falling and becomes less than 1, then we usually take up for surgery. Usually it is better to take up once when the patient is not infected, if he is otherwise stable.
Any inputs from Narayana? What do you do? Suppose your patient has severe cardiac failure, admitted to ICU, large VSD, and was in the ICU for, let's say, 4 or 5 days, maybe requiring NIV, or sometimes even intubated. So how you manage, like what is your policy of managing the preoperative period of these patients?
Yeah, sir, may I take this? Yeah, very similar ideology to what Madam mentioned. Look up for PCTs. They inevitably are on antibiotics the moment they are in the intensive care with endotracheal intubation. PCT 0.1 or below is something which we accept. A CRP in a single digit is something we'll accept. More than this, what we routinely do is inevitably our PCTs and CRPs on the higher side. A decreasing trend, a significant decrease in trend of CRP is something which we look up to, because inevitably, even if they're extubated, they are unlikely to leave the ICU. So they're always around the scenario to get infected again. So one more addition point we did in our unit is a decreasing trend of CRP, which we look positively and look forward to get a window to operate on these children. This is one specific additional point.
What about any prophylactic antibiotics? Do you, and any culture, do you electively send cultures?
Yeah, we do electively send culture for these children preoperatively, but we do not wait for the reports of the culture to ensure that we operate them. And the baseline values of PCT, CRP, and the decreasing trend of CRP is what we hold on to operate. But in the background, yes, a culture keeps growing to ensure we haven't missed anything, so that we can continue the sensitive antibiotics in the post-procedure period.
If I may add, sir, falling trend is about 30% per day. Is a reasonable falling trend.
Yeah. So we usually tend to use that 30-35% decrease in trend of the CRP per se. At times, we don't even very strictly hold on to the counts. For some reason, in our recent experience, we've held on to CRP as a more reliable indicator than the counts or the PCT or the individual static value of either of them. Yes, there have been scenarios for us that, everything was fine. The count CRP is absolutely okay, nothing grown, and we operate on a child, and next day we are in an absolute septic picture. The foci might still be there. They can get flared with SIRS of the pump that is added on. But yeah, holding on to these basic values has helped us take most of the kids out of the theater and in the early post-operative period. And I think we, as a consensus, stuck to these points.
Thank you, Sridhar. For last question from me is, I think it is to Bhargava. I think he mentioned about oxygen delivery, if I'm right. Do you have this oxygen delivery index of 280 ml per minute per meter square in babies also? Do you use the same formula, or what is the take on oxygen delivery in infants on CPB?
On CPB.
Yeah,
CPB,
I think you mentioned something about oxygen delivery, if I'm right.
DO2I, yeah, DO2I.
Yeah, DO2I.
DO2 index, the DO2.
Yeah.
Index DO2, as per the recommendation, is about 272.
About 280.
280
That is
is
in adults. In children, it is 310. I think the CPP guidelines mention 310 for the children.
Right.
Higher DO2I.
Thank you so much. I think it's time to end this session, and I'm grateful to all of you. And I would like to request Dr. Rupa Sridhar to say final comments, and then we'll close. Dr.
Sir,
Rupa, are you there?
yes,
Yeah.
sir, I am here.
Yeah.
So in the olden days, means
Yes.
around the time when you were in Chitra and little later after that, we used to get uncorrected tetralogies come with brain access coming to the neurosurgery OT. And
Yes.
there, if aspiration, etc., is not enough, they will do open surgery.
Yes.
And there it was what was noticed that the hemoglobin, if it is some 18 or 17 pre-op, and if it comes down to 11, 12, etc., in the perioperative period, then the mortality used to be high.
Right.
So then it was Padmanabhan sir had suggested that we will give blood.
Right.
Maybe. So in tetralogies, uncorrected tetralogies, when they come for non-cardiac surgery, we should not allow the hemoglobin to fall too much. And if it falls during surgery, we have to give blood, although the hemoglobin is say 11 or 12. Because it has
Absolutely.
come down from 18.
Absolutely. I totally agree
Yeah,
with you. And this policy of keeping the hemoglobin 7 or 8 gram does not hold
yeah,
good.
yeah,
When
yeah.
you go put patients on VV ECMO, there the hemoglobin has to be maintained between 12 to 14 grams per cent, because
Uh,
their saturation is more important than the actual the saturation of 89, 90 is acceptable. So they maintain a hematocrit of greater than 35 and maybe
yeah.
40. With that final comment, I would like to thank all the participants. I profusely thank Dr. Srinivas, Dr. Rupa, Dr. Keshamurthy for being the moderators for this session, and the speakers have done a great job. All the 4 talks were excellent, and I look forward to having more of your talks in the next sessions. And thank you so much. Thanks others who have participated, Sridhar, Hemant, and maybe Sonali and others. Thank you so much. Looking forward to having you again. On behalf of ICA, I would like to thank all the participants.
Thank you, sir.
Thank you, sir. Thank you, sir.
See you
Thank you very much.
next
Professor.
Wednesday with a new topic. Thank you.
Discussion. Thank you very much.
Thank you so much,
Thank you, sir.
everyone, for joining this session. Planet is really glad to have all these brilliant people together. So, with all your permission, shall we conclude the session for today,
Yes,
sir?
yes, yes.
Yeah.
Yeah.
Thank
So,
you.
with all your permission, I'm concluding the session for today and looking forward to hosting you again.
Please
Thank you so
join
much.
us on Sunday for a talk by Nilesh Zuvekar from Pune.
Yeah, we'll try, sir. Yeah.
Thank you, thank you, thank
Sure,
you,
sir. Thank you.
thank you.
Thank you so much, everyone. Have a good night.
Thank you.